right, welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Tim Wetherill. He's a physician executive. Today's Kevin MD article is Why AI is the Perfect Neutral Arbiter for Healthcare Claims. Tim, welcome to the show.
Hey, thanks, Kevin. Excited to be here.
All right, so briefly tell us a little bit about your story and then the article itself for those who didn't get a chance to read it.
Sure. I'm a general surgeon by training. Grew up in the Philly area and then trained at the University of Kansas and did everything from trauma to robotics to bariatrics in private practice, and then moved to the VA where I was chief of the VA for Montana for a bit. And then not by any plan, but just gravitated to the payer world one day and worked for some blues plans for about 10 years. And then transitioned to an AI startup where I'm the chief clinical officer today at Machinify.
All right, excellent. So, for those who didn't read your article, Why AI is a Perfect Neutral Arbiter for Healthcare Claims, tell us what this article is about.
Yeah, it's really about using AI to read through medical records and claims and find the truth.
Mm-hmm.
And we all know that medical records, especially when you're dealing with like long inpatient stays, I mean, the average length is like 800 pages now. We've even seen one that was 100,000 pages. Like, yeah,
Wow.
that actually happened. Yeah, and you'd think that was like for somebody who was in the hospital for 6 months. I think it was for a bill that was under $5,000. So for something ridiculous. But trying to filter through all that is really difficult. And we all know that humans are humans and we have error rates and we have different ways to interpret. I mean, like, go ask, two different orthopods about how to treat a fracture. You'll
Yeah.
get different opinions sometimes. And we all know how it is. It's part art, part science. And that comes through, unfortunately, in reviewing claims and medical records. And it's not completely a hard science. And there's bias and there's also, pressure from above to, in some organizations, and pressure might be for denials. I never saw that, but I think some organizations might have that. But the AI isn't about that. I mean, it just wants, it spits out the facts and the truth. What you do with the truth is a different story. That's up to you. But our job is give the reviewer, whether it's a nurse or a physician, enough information to decide what actually happened and whether the code is valid and, how the determination should be rendered.
So give us some insight in terms of the payer side. So before the advent of AI, how were claims typically evaluated on a routine basis?
Yeah, so claims the bills that come in and they're pretty superficial. It's got ICDs and CPTs or HCPCS codes and patient identification. So there's not much there. So a lot of that is automated. If they do get flagged, it's usually flagged for reasons that are not great, like, oh, there's a certain dollar threshold, or it's, an unlisted code came in, or I don't know, something fishy is there,
Mm-hmm.
billed for 18 wheelchairs in a day, something like
Yeah.
that. Then when it gets handed off to a reviewer, it can be anybody from a coding specialist to a clinician who usually looks at the medical record to decide, okay, what actually happened here? Does this claim match up to the
Yeah.
record? Now, the payers still to this day have a tremendous manual process. It's not super sophisticated. They have tremendous amount of policies and guidelines and rules that need to be applied. Some are payer specific, some come from CMS and the feds. But when you have so many rules, and these
Mm-hmm.
rules can be 30-page documents,
Yeah.
and you're asking a team, 50 clinicians to apply them, I mean, you can do the math and you figure out what happens.
Yeah.
So,
So give us a sense of how your particular AI system, how would it work in practice?
yeah. So sepsis is probably the most commonly abused diagnosis submitted for inpatient stay because it pays the most. So if you
Mm-hmm.
are a facility that uses DRG is a grouping. So it basically tries to say, well, not all conditions are the same. So let's pay the hospital based off of how much resources were used. So sepsis is highly abused because it pays a lot. Sepsis criteria are a little nebulous and difficult to tabulate, but we work with a payer per their policy and their guidelines. And we don't make up the science, neither does the payer. I mean, we use clinical literature. whether it's sepsis 3 criteria or what have you. It's based off of sound science. And we use those rules and we train the AI to look through the record and find the specific details.
Hmm.
So sepsis is about, do you have an infection? Is there dysregulated immune response? Is there organ dysfunction? We are categorizing that and giving the user an output. We are not necessarily making a determination. We're not in that business. I mean, we still believe that, this is not self-driving cars just yet.
Hmm.
So the nurse or the physician who's reviewing the output of the AI system will then also have the record there to validate and confirm that the AI, was correct and was accurate and consistent. And what we have seen is that the clinicians are now reviewing records much more quickly. So
Hmm.
that means that providers are getting paid, sooner. The accuracy is improved and the consistency is absolutely improved, that's good for everybody.
Do you find that there's any discrepancy between the human reviewer after the first pass with the AI?
Yeah, there's always room for error. I mean, some of it is just the OCR, the optical character recognition, just doesn't work. It fails
Hmm.
because the PDF is really dirty or messy. And so the numbers might be, misinterpreted. The other thing is, there are those corner cases. I mean, we all know it, the zebras. And we train the system to actually call that out and say, like, I'm not sure, or this needs further investigation, or, again, we respect, and that's, I'm very proud to work for a company that hired a clinician to say, like, medicine is not black and white, it's
Yeah.
binary. So you are going to need that expertise to interpret and make that judgment call. And absolutely, I mean, what we really focus on are, like, let's get the easy cases out of the way so that the clinicians can use their brain power and their
Hmm.
expertise to do the job that they were hired to do. So it's really about less paperwork and more skill set.
And now, is there any feedback mechanism in terms of the AI evaluation getting back to the clinician and the local hospital system in terms of how they could improve their documentation to better fit the coding that they're submitting?
Yeah, there's been feedback from payers to providers to hospital systems and doctors all the time. What's crazy is that, I mean, I used to get those letters. I never read them. I like
Yeah.
tore them up and would throw them away. So, I mean, I'm a bad example of learning and adapting.
Hmm.
But what payers know is that most providers actually don't change their behavior, even though that behavior is very simple to change.
Hmm.
The AI system, there is absolute feedback. It's both automated and manual. So, we learn from the users plugging in for information or adjusting the output. And then we also have, feedback sessions constantly
Sure.
with the teams to say, what'd you like? What'd you not like? What was good? What was bad? So there's lots of, I mean, especially at this stage of the game, there's tremendous amount of feedback going on.
So, how common is it for the AI penetration in terms of the payer to evaluate billing claims? Is it fairly common that this is happening? Because it seems like an intuitive next step.
Yeah, payers are, from a tech standpoint, they're not the most sophisticated industry. I mean, they
Hmm.
still use faxes and DOS-based systems that aren't even supported by the companies that made them, 20 years ago. And I'm not kidding. I mean, there are still systems that are made in the 90s that are
Yeah.
core functionalities of payers. So they are trying. Sometimes the motivation it just isn't there. Like, yeah, the feds pass rules and everybody's complaining, but till there's something pretty harsh, like a new standard or a new requirement from CMS, it's not going to happen overnight. I think there is the will and intention, but this industry moves, so damn slow. And unfortunately, this is one area where it's like it's not that difficult to put some of this in play. I mean, especially as you have software systems that are cloud-based that you really don't need to integrate much with your legacy systems. I mean, you can adapt, but it's more of a culture problem than anything.
So, currently, as we're speaking in April 2025, would you say just a minority of payers are using AI tools to adjudicate billing claims?
Yeah, I bet it's the minority of the claims that actually, I mean, look, there's probably some and I'm using air quotes here, AI that touches the majority of claims, but it's pretty unsophisticated stuff. It's like matching an ICD to a CPT code.
Yeah.
Like you can call that AI, but it's really just a rules engine. But like true benefit of improving quality output with AI, I think is absolutely a minority right now.
So I can see some usefulness certainly in a primary care setting because, as you know, I'm a primary care physician. A lot of doctors, we just simply put our own code in after writing the notes. So I can see a scenario where AI can just evaluate whatever we've written, evaluate the chart, and just kind of give a suggested code based on our A and have us not worry about it.
Yeah, I think that's absolutely an opportunity. I think that the only concern I have with solutions like that, and you can flip that to the payer side as well, is I personally I don't want AI to have a bias or intention underneath that says, I want Kevin to get maximum profit out of this visit.
Yeah.
Like that, in my mind, that should not be the rule. It should be about, Kevin, you documented this.
Hmm.
Here's what the CPT code should be for that visit, that problem, that procedure, what have you, and not try and nudge you. Like there was a use case that the DOJ nailed an EHR company. This was a few years ago. I think it was 2019. There was a kickback scheme with an opioid manufacturer. And so docs were getting prompted to prescribe more opioids.
Yeah.
Well, we all know how that works out. Like that kind of stuff, that nefarious business practice, we need to all be aware of as physicians and know like, okay, if you're going to give me an AI tool, that's fine, but let me understand what the intent is and how it was designed. And that is a step that I think we are missing. I know that a lot of companies do have physicians, a lot of companies don't have physicians, and there is essentially zero federal oversight over this stuff. I mean, there's probably oversight in the clinical stuff,
Hmm.
but the business side, there's very little oversight over. And that's what makes me nervous that this could just accelerate the current problems we have.
So right now, you're saying there's just not a lot of safeguards because the AI perhaps can be manipulated with a prompt, saying what more can the doctor add to maximize revenue, or even for the payer side, how can the AI deny certain procedures or medications? So right now, we're kind of in a wild west. There's not a lot of safeguards both ways.
Yeah, I mean, the only safeguard that we have is the oath that you and I and others took, and that we have a role in this. And I mean, that might sound scary to some people, but I mean, even though I'm not practicing anymore, I still live by that oath, and we'll. I mean, ultimately, I respect that anything I do, even though we're so far removed,
Yeah.
there's a very powerful human-to-human interaction that happened, and I am not going to make that worse. Like that is, if anybody starts pushing me to do that, I'm gone. So
So on this podcast and on Kevin MD, we always talk about the different ways AI can intersect with the various aspects of healthcare. So specifically as it relates to billing and coding, and you're an expert in that, where do you see the next steps be? Because so much has changed over the last several years or so. So what do you see in the foreseeable future, specifically with that intersection between AI and billing and coding?
yeah, I think there's a huge opportunity to again to have this neutral arbitrator that both sides can rely on and trust, both
Mm.
payer and provider. And that can do two things. It can stop the fighting and improve the timeline so everybody can get paid accurately and quickly. And there's no guessing about what's going to happen. And I think you know, if we can get out of the way, there's greed on both sides.
Yeah.
No one's innocent here. Like, let's not play games. And if we can get beyond that and realize that this arms race that we've been in for decades about coding and billing, if we just agree that this is essentially a mutually assured destruction scenario and just say, hey, let's just agree on using this one platform or system that can arbitrate neutrally, I think that's the way to go. And I think that is possible.
Hmm.
But again, it's the tech's the easy part. It's the culture part
Sure.
that is difficult.
So a tangential issue, you could easily see a scenario where AI can take over all of the coding related issues when it comes to a chart. What about the profession of coding itself? Do you worry about that whole profession of coding just going by the wayside and being replaced by AI?
No, not necessarily. In fact, they're really important to help. AI is based off of rules, and coding is really complex. I mean, I remember just trying to learn it, and I still get taught by my coders every day about these little nuances. So there are so many scenarios, and ultimately it's based on the language we use, and it gets a little bit legalese in how you interpret records, but you need those experts to help train the models to teach it and learn it. I think where we really want coders to evolve is we keep getting more and more complex and confusing with coding. And maybe I'm naive, but I'd love to see us go the other way and say, let's try to simplify this. I mean, every time we try and, like DRGs, they were started in the 80s and they were a way to simplify and try and, control costs by putting different services in different buckets. And to my understanding of looking at the literature, there has never been an indication that has controlled costs at all. In fact, all it did was create loopholes that people were able to, take advantage of. So I wish there was a way. Maybe again, I'm just being naive to think that we could do that. But
We're talking to Tim Wetherill, who's a physician executive. And today's Kevin MD article is Why AI is the Perfect Neutral Arbiter for Healthcare Claims. Tim, let's end with some take-home messages that you would like to leave with the Kevin MD audience.
yeah, sure. I think one of the biggest lessons that I learned, I had been in pure private practice. I was employed. I worked at the VA. I did some prior auth reviews for Blue Cross plans, and I thought I knew a lot. And then once I got in the payer space, I didn't know squat. Like it is incredible how complex and confusing this world can be. And there are a lot of things that payers do that are good. And I think that a lot of the physician voices are very loud and uninformed, and they're working on, denial letters and their opinion about care. And the problem is that because you don't understand the other side, it creates more chaos. And especially when physicians are helping design legislation. Like some of the prior auth legislation looks good on paper, it's actually increasing denial rates. So we need to have people who are curious and willing to learn about both sides, and then hopefully design solutions based off of that.
Tim, thank you so much for
Yeah.
sharing your perspective and insight. And thanks again for coming on the show.
Thanks, Kevin. Really appreciate it.